team Thursday, and we're starting work on H237, which is in regards to prescribing for doctoral level psychologists. First person we have with us is Brandon Campo. So you want to come up and join us?
Sure. Yeah.
That's the hot seat.
This is where all the magic happens. So thank you for having me. I'm Dr. Brandon Campo. Most of my work here in Vermont is doing psychological evaluations and neuropsychological evaluations. That's probably 90% of my work. I'm also a Marine Corps veteran. And the other 10% is doing, therapy with folks. I am in support of this bill for many reasons. After folks leave a psychological evaluation or a neuropsychological evaluation, now what? In my recommendations, I will often recommend, psychopharmacological intervention, but that's easier said than done. I have a lot of my patients afterwards will say, Brandon, I have to wait 6 months, sometimes even longer, to get access to a psychiatrist because their primary care physicians are a little shy and skeptical of providing psychotropic, that's okay, of providing a psychotropic prescription because they don't feel comfortable. And I agree with that, and that's fine. But it's now what? They don't have this, there isn't a psychiatrist in every corner. So we're looking at, 6-month wait times, if not longer. So folks here in Vermont, will have to go try to make an appointment in Dartmouth or, hope, and pray that they can get into UVM. Even in my world, for a neuropsych eval, if they don't come see me, they're on a 3-year wait list for Dartmouth or UVM. And what do I tell my patients? Keep it together for 3 years. We'll get you in, I promise. And it's the same thing with prescriptive authority. If I have, a patient and I diagnose them with some sort of comorbidity and they have to wait 6 months, now every time they are feeling emotionally dysregulated, do they go to the emergency room? So now we've just flooded the emergency room now with overburden that healthcare system, in addition to cost as well. And we know that in the next decade, at the current trajectory that we're going on right now, there's already a psychiatry shortage. And in the next decade, we're looking at upwards of 21,000 less psychiatrists to, prescribe, and for us psychologists, we're looking to work collaboratively, with other providers. I think there's less than 5% of psychologists nationwide that are doing prescriptions and only prescriptions. Most of them are doing prescriptive authority in the 7 states that we have, in addition, with, therapy. And we're not just seeing one hit and then we'll catch you in a month or we'll catch you in 3 months for a med checkup. Most of our patients are coming in on a weekly basis. So it gives us a really good pulse on what is going on. So if they were to get, a script for something, we are going to see them the following week to see if there's any rebound effects, any side effects, and then, move and adjust accordingly. So what we're looking to do is essentially bridge that gap to access, because most of the time in rural areas such as Vermont, there isn't, number one, a psychologist in every corner, but there isn't also a psychiatrist in every corner. And I work very closely with a lot of primary care physicians, and they'll say to me, Brandon, we're going to have to do a referral here because I don't feel comfortable prescribing outside of my lane. And that's where the psychologist will come in and work collaboratively, with those folks. Yes, ma'am.
Can I interrupt you for just a moment?
Yes, ma'am.
Because I'm realizing, so first of all, typically we would have our legislative counsel in to do a walkthrough of the bill, which would be forming questions.
Sure.
And things that we don't know. Unfortunately, we couldn't get counsel in until a little bit later this morning. Can you just sort of explain to us, you said you do neuropsych exams.
Yes.
Can you kind of give us an idea of what that is, what it entails?
Sure.
What, how your job works.
So I'd be more,
Tell us about how your job works.
right.
This is a new topic.
Oh, wonderful. I'd be more than happy to explain because I love what I do. So typically what will happen is I'll either get a phone call from the individual themselves, or I'll get a referral from a primary care. And it'll usually be something, it could be something from autism. It could be something to, attention difficulties, memory issues, a whole host of things. So then I'll reach out to the patient. I'll tell them, hey, I got a referral order from your primary care. Let's schedule a 1-hour clinical interview over the phone, see what is going on and see how I can be of service to you. And if I can, wonderful, I'll get you in. If I can't, then I'll make the appropriate referral. So after a 1-hour clinical interview, and I have my referral order next to me, more often than not, the referral order might be for, say, memory deficits, or it could be attention or ASD. Typically, there's something else going on, some type of comorbidity. Could be trauma in addition to that really wasn't on this referral order. After I get all that information, I will schedule someone to come in for a full comprehensive neuropsych eval. We're looking at 6 to 8 hours of testing. This isn't, come on in for a half hour and you're done. Sometimes folks can have that mental marathon and do it all in a day. It's a lot of heavy thinking. So we do it over the course of 2 days, 2 4-hour sessions. They'll come in, I'll do cognitive testing. I'll touch on some achievement, which really works on working memory. I'll do a lot of social, emotional, and behavioral testing. When that is all done, then it takes me a few hours to score everything. Once I go through everything, then I will, at the end, if warranted, I will make a formal diagnosis and a whole bunch of treatment recommendations. In those treatment recommendations, there will be psychopharmacological interventions in there as well. Then I give them a copy of the report. We go over it for about an hour, questions that they may have. And folks will do a couple of things with that report. If I do make a med recommendation, they will bring that report with them to their primary care. More often than not, they'll sign a release so that I can have a conversation with their prescriber as well. If folks are in therapy, they'll give a copy of that report to their psychotherapist so that they can adjust, whatever type of treatment modalities there are accordingly. But that's the basic gist. It's a very cumbersome, process. So you're looking probably from start to finish, probably 30 hours, grand total with, interviewing, performing the neuropsychological testing, going over the report and so on. It's about a 30-hour process. So it's not just a quick hit, good luck and I'll see you later. So that's the process, ma'am.
Thank you. Daisy has a question and then Mari.
And just to be clear, you're working with folks who have complex conditions or dual diagnoses or
Yes.
Okay, so if I were looking for help with postpartum depression, anxiety, psychosis, I wouldn't necessarily be on your wait list.
You could be. Yes, absolutely. Yes.
Okay.
Because I like to think of these diagnoses as drunk track runners. Everybody starts in their lane and you watch it on TV and they all finish in their lane. The difference here is with all these diagnoses, they start in their own lane, but as soon as the referee shoots the gun, they all run into each other's lanes. And now it becomes to differentiate what is doing what. Is it anxiety? Is it trauma? Is it attention difficulties? And that's where the testing comes into play, where I can tease all of these things out and say, this is really your trauma at work going on here. That is affecting your memory. That is affecting your attention deficit. Because if someone just said anxiety and we're just treating the anxiety, what do we do with all these other comorbid conditions as well?
So again, with postpartum or something, I also would be in the back of Psychology Today, getting on the wait list of psychiatrists, right? I wouldn't necessarily be referred by my primary for a neuropsych eval. But in my personal experience, I was referred to a psychiatrist. Would you say that's the norm, or are people normally referred for a neuropsych eval?
I would say it depends, what's going on, how they're presenting. Familial history, is a big one. So if somebody has a mood disorder, bipolar, typically there's a big familial history there. Even with attention-related issues, ADHD, there's a genetic component there. So I would say it depends. Not only on a familial history, but also who is making the referral, as well.
Yeah, I'm just trying to get a sense of what the typical path is for a person as they're navigating access to necessary medication.
Yeah, I don't know if there's a typical, this is a textbook pathway here. I'll even get, calls from, psychotherapists, MSWs, in the community as well. And they'll call me and they'll say, Brandon, there's so many moving parts here. I don't know what to kind of put my finger on. This is where I need your help to kind of sift through and parse through what is really going on. And these are the behaviors as a result of, this particular, diagnosis or whatever.
All right. Thank you. I am going to follow up. I have the same question as
Sure.
Representative Rebecca, and I'm going to ask it from a different angle. A prescribing psychologist with the requisite training that is outlined in the bill that we're discussing today. Do you believe that it's most likely that, of course, they would not be necessarily doing the assessments, evaluations and treatments that you do as a neuropsychiatrist, but more likely they would be taking care of patients with issues around anxiety and depression are the most common that I can think of. And with their current training and experience, and then adding a collaborative practice agreement and the required training in this bill, they would also be qualified, in your view, to refer patients to someone like you if they felt that there was something deeper or in addition to if there was complex anxiety or depression. So I'm looking for your, do you it sounds like you do support clinical psychiatrist, prescribing authority of clinical psychologists.
Yes, ma'am.
And the cases you're talking about that you treat would most likely not be who they are treating. They would be treating less complex cases, and they would have the training and the ability to, if they did take in a patient that had more complex needs, they would know to refer to someone like you.
Sure. I think, one of the neat things of what we do is that, first and foremost, obviously do no harm. But I don't subscribe to working inside of a vacuum anyways. I believe in more of a collaborative model. It's always nice, even in those instances when I get referrals from colleagues, that they want to get another set of eyes on this rather than just looking through a singular lens. And this would be the same exact thing for a prescribing psychologist as well. We already do that now and collaborate, with our other colleagues, with medical doctors, naturopaths, and so on. So I look at this as another tool in the toolbox. If your only tool is a hammer, well, then guess what? The whole world looks like a nail. So this is just another tool in the toolbox for patients to access care that they otherwise would be on some sort of a wait list for 6 months or longer, end up in the emergency room. Yeah, I do had a case a few months ago where I did have a fella, come in. I did testing for him because I'm seeing a lot of adult autism referrals now. In the past 2 years, it's just been out of control. I worked with this young man, I call him young man because he's 28, came in for an autism referral through his primary care. I did end up diagnosing him, with autism in addition to, in generalized anxiety disorder. And what had happened, he's an intellect, but like what a lot of folks do now is they want that immediate gratification. So they'll go on the internet, they'll Wikipedia something, WebMD something, or now TikTok something. And he went on and he thought that, oh, well, marijuana or a tincture, can suppress some of my anxiety and social discomforts. Well, he got access to a tincture and he was not well versed in the dosage and he took some and he ended up in Central Vermont Medical Center in the ER. He was there for, how many hours he was there, and he leaves with a bipolar diagnosis of one that I did not give him because in that short window and period of time, he was exhibiting, some manic activation. And I get it, but it was a short window of time that he was there and left with a heavy duty diagnosis. Bipolar is not a diagnosis that I take lightly or even hand out lightly. He left with that and with a script. So that diagnosis comes with heavy duty medication as well. I get a letter from, CVH, as does his primary care in Stowe. And he calls me up and says, Brandon, what is going on here? And I explained, this is what's happened. I've spoken to him already. He says, I do not support this diagnosis. As I do not as well. And the nice thing is we follow our patients, or at least I do. So the following week, he did come in and we discussed this, and now he's been fine. And I manage his progress on a weekly basis because he comes in. So that's the nice part about what it is that we do. It's not a one and done. I get to see my patients on a weekly basis, see how they're doing or see how they're regressing, and then we can adjust accordingly. And I work close with his primary care physician, which I appreciate that collaboration at the highest. But that is just one example of what is going on. This one and done hit, and then they're leaving with a heavy duty diagnosis and a script to go along with it that can be, in some cases contraindicated by what they really have. So this intimate relationship that, that we have with our patients, it tends to look a little bit different by design, of course. Thank you, ma'am.
I had interrupted your testimony.
Oh.
Did you have further? Okay.
No, ma'am.
Thank you so
Thank you.
much for
No,
the.
thank you for having me. This was a pleasure.
Actually, I have one question.
Yes, ma'am.
So what is your training? So tell me
Yeah.
about the training that you've received.
So I've got my undergrad degree from Norwich University. I was a cadet there. I got my Bachelor of Science in Sports Medicine Biology. Afterwards, I went on to St. Mike's. I got my master's degree in clinical psychology. And then afterwards, I went out to Minnesota and I got my PhD in clinical psychology as well. For the prescriptive authority, I would go back and get a 2-year to 3-year Master of Science in Psychopharmacology to be in line with the training, for prescribing. I did a 2-year internship at the New England Psychological Assessment Center in Westboro, Massachusetts as well.
All right.
Do you have access to a pharmacist, or pharmacy professional, if you have questions about prescribing psychotropic medications, psychoactive medications?
Well, it is probably, as a matter of fact, there's one probably just a little bit, probably for me to Representative McFawn in a building right in front of ours where I practice. Yeah, Mountainside Pharmacy, brand new pharmacy in Stowe. It's literally a stone's throw. So yes, ma'am.
Leslie.
I apologize for being late.
Sure.
And if this was answered, how many doctoral level psychologists are there in Vermont? And what would it take to get them to prescribing level, given this bill?
I don't know. That's a great question. I don't know the exact number of doctor level psychologists in Vermont because Vermont is the only state right now that allows master's level psychologists to practice independently. As far as doctorate level, I don't know the exact number on there. But the formalized training would be in alignment with the other 7 states that are currently have prescriptive authority. And it typically looks like a doctor level psychologist going back, obtaining a master's degree in psychopharmacology specifically, which would then bring them up to par with nurse practitioners, physician assistants, psychologists in the military, who prescribe as well. So there is a robust training. It's not just, hey, I got my doctorate degree in
It's not like go for
psychology.
3 credits and something or other.
Right, and here you go, you
Yeah.
graduated and you have and here's your prescription pad. No, it's not like that at all. These programs, depending on how motivated an individual is, could be upwards of 3 years of doing that, plus additional, training thereafter, accruing hours, working under the expert tutelage of somebody else who's been doing this. So this isn't a willy-nilly thing. This has definitely been methodically, planned out, and 7 other states are definitely on board with this, ma'am.
Yes, may I, so we see it as a workforce expansion, I do anyway. But I'm wondering how much impact it would have. That's my question.
Mhm.
And what's the time frame? So the runway seems long,
Mhm.
of getting people actually up to being able to prescribe at that level. So that's what want
Yeah.
to understand a little more about.
Yeah, well, and I would definitely say this is a marathon. This isn't a sprint. As I look at, some of the data, within the next 10 years, we're going to have a shortage of approximately 21,000 psychiatrists anyways, just because of the workforce. Yeah, national, yes, just because of the workforce, getting older, demands, access, and so on and so forth. And this is just another way to help fill the void. Primary cares are maxed. They really are. Nurse practitioners, are maxed. So, after everything is busting at the seams, which we're kind of already are, what do we do then? Who helps that? Otherwise, we're going to have, our ERs, inundated with, individuals who are in some sort of, psychological crisis, emotional dysregulated. And that's not what the ERs are meant to be. And then that just shifts the folks that need those ER services, to longer wait times as well. And this is another way to help, fill that void. But I would definitely say it's a marathon.
Yeah, so if I may, we need to move on or.
We do need to move on only because, and I wanted to ask Sarah and Philip, I want to be respectful of your time, but would you mind if we pivoted to our legislative counsel, who's now in the room, to give us a walkthrough of the bill so that, we actually have an idea of what's in the bill? Because I know we only have legislative counsel for a short time. Great, thank you very much. So we'll get to you right after that. Thank you so much.
Thank you for having me.
And
Appreciate your time today.
My Katie wants to come up.
Morning.
Good morning.
Katie McLean, Office of Legislative Counsel for the record. Let me share this screen. Okay. So we're looking at H 237. It sounds like you already have a head start and you are familiar with the bill. This authorizes prescribing by doctoral level psychologists. In section 1, we are amending, we're in Title 26. So this is where we regulate professions. And there is already a chapter on psychologists. So we're amending that section on psychologists. We have a definition section, and we're adding a new couple of definitions. A collaborating practitioner means a physician licensed to practice medicine or other prescribing provider as approved by the board who generally prescribes the prescription drugs for the treatment of mental health condition to the physicians or prescribing providers, patients, and the normal course of the physicians or prescribing providers' practice of medicine. When we say the Board of Psychological Examiners. Drug means an agent related to the diagnosis, treatment, or management of a mental, nervous, emotional, behavioral, cognitive, or substance misuse disorder. Prescribing psychologist means a licensed doctoral level psychologist who has undergone a specialized training, has passed an examination as determined by rule, and has received a current prescribing specialty under 3019, a section we're going to look at soon, that has not been revoked, suspended by the board. I will say one criticism I have of the draft, which is really a criticism of myself as I went through it last night. The terms specialty and license are kind of used interchangeably. So I think if you're looking to amend this, we should make sure that when we're referring to this additional endorsement that we're using a word endorsement or specialty, and we're not referring to it as to imply that there's an additional license. So here we've used specialty, I've used specialty, but there are other places where I refer to it as a license.
Can you flag that for us?
Yeah, I'll try.
Okay.
Now it'll jump out to you now that I've said it.
Mari.
The line 2, pass an examination as determined by rule.
Mhm.
Where does the rulemaking happen in this instance?
We'll get to a section on rulemaking. I wouldn't say it's much more prescriptive as to what the exam includes in that section, but there is a rulemaking section. And a lot of the sort of details about how the regulation of prescribing psychologists happens is in that rulemaking section. Prescription drug, we're cross-referencing existing language and statute, and then prescriptive authority means the authority to prescribe or discontinue prescription drugs. Prescriptive authority shall exclude the authority to dispense, administer, distribute prescription drugs. So that was our definition section.
Leslie? I'm not sure if this is the right time, but is there other collaborating practitioner sections in other aspects of the law? Is this unique or is there other places?
I would have to do some
Okay.
research, but
Okay, no, don't.
I can do that.
No, don't spend a minute on it.
Powers and duties of the board. You know, if you're having OPR, which I'm assuming you will,
Yeah.
they would probably know off the top of their
Yeah,
head
yeah,
without
thank you, that's
having to
helpful.
think much more.
I don't want you to spend a minute on it.
Okay, so now we're moving down to a new section. This has to do with the powers and duties of the Board of Psychological Examiners. So the board shall, oops, Mari has left, Representative Curtis has left. But this is where the rulemaking happens. So the board shall adopt rules necessary to perform its duties under this chapter, including rules that specify educational and other prerequisites for obtaining licensure. And then we're striking language, explain complaint and appeal procedures to licensees, applicants, and the public. Retaining language, explain continuing education requirements. New language, regulate prescribing psychologists licensees pursuant to 3019. That's a section we'll look at specific to prescribing psychologists, including the length of clinical rotations, appropriate instructional settings, and prescribing authority. So that's all left to rulemaking. Top of page 4, regulate collaborative practice agreements pursuant to section 3019, including collaborating practitioner qualifications and annual competency evaluations. So that is for rulemaking. And then we get to this section 3019 that we keep referencing. So this is a new section being added to the existing chapter on psychologists, and this is specific to prescribing by doctoral level psychologists. So here is one of the places where I refer to it as license, line 8, prescribing psychologist license instead of endorsement or specialty. So potentially a place to change. A psychologist doctorate may apply to the board for prescribing psychologist license. There it is again. The application shall be made on a form approved by the board, include the payment of any required fees, and be accompanied by evidence satisfactory to the board that the applicant, first, holds a current license to practice psychology at the doctoral level in this state. Second, has successfully completed the following minimum educational and training requirements, either during the doctoral program required for licensure under this section, or in an accredited undergraduate or master's level program prior to or subsequent to the doctoral program required under this section. And then specifically, a postdoctoral training program in psychopharmacology accredited by the American Psychological Association or its successor, and 2 years of supervised practice for not less than 20 hours per week in a clinical setting agreed upon by both the psychologist doctorate and collaborating practitioner. Other requirements, the person has completed a national certifying exam as determined by rule and meets all other requirements for obtaining a prescribing psychologist license as determined by rule.
Missed the rules section, Mari.
Sorry, that was an important call.
It's okay. It's section 2, I think, section 2. And so all other requirements that sort of create some flexibility that OPR could create some more detailed requirements than this is required. You know, I said OPR, but I think it's the board that has the rulemaking authority, that the board could create more specificity.
Katie.
Yep.
Section 3.
Yeah.
Page 4, line 9. It says, no, excuse me. It's the line 8.
Mhm.
A psychologist doctorate may apply.
Mhm.
They have to apply.
Not if they don't want to have the license, the prescribing endorsement. I mean, you could be a psychologist at the doctoral level and be licensed by the state to do that. And that's fine, but if you would like to prescribe, if you would like that endorsement through the state, then you have to apply.
Have to apply.
But it's a choice.
yeah.
You don't have to do it if you don't want to, but if you would like,
But if you want to do
if
this.
you want to, you have to.
To the board. Thank you.
Yeah, Leslie?
So on page, at the beginning of section 3, when they talk about having completed a master level program prior to or subsequent to,
Mhm.
I'm just wondering, and I'm not sure this is the right place to ask, but if you completed a master's level program that gives you prescribing authority,
Mhm.
couldn't a master's level person prescribe at this level? I'm confused about the doctoral level versus the master's level, I guess.
Yeah, I don't think I'm the right person to answer this,
Okay.
but legally, as this is structured, no, you wouldn't be able to. You'd have to be the doctoral level.
Yeah, you have to have the master's plus the doctorate.
Yeah.
Or the doctorate plus the master's, but they don't stand alone. But they could stand alone. Or.
Yes, but you wouldn't have the authority to seek the specialty in the state, the prescribing specialty or
Because of
endorsement.
the way this is written.
Yeah.
Right.
You'd have to first have your doctorate,
And then they say
And then
you
go
can
get
get a
it.
master's before.
but you would then also have to get a doctorate because you wouldn't be a doctoral level.
By the way this is written, but
Able
once,
to-
once again, as a workforce bill, which is how I'm thinking about it, there are many perhaps qualified master's level prescribers as nurse practitioners or master's level prescribers, psych NPs. So I'm just trying to understand why it was focused on doctoral level and not including master's level prepared people. And I don't know who
We're
answered.
gonna have an OPR in,
Okay.
so I think they'll be able to explain to us a little bit of the difference between the master's level and doctoral level psychologists.
Preparation.
training
Yeah,
They have at the state.
thank you.
In subsection B, criteria for prescribing medication, there is a written collaborative agreement that is required for all prescribing psychologists practicing under, here it is again, prescribing psychologist license instead of endorsement or specialty issued pursuant to this section. The issuance of prescriptive authority by a collaborating practitioner to a prescribing psychologist may only include prescription drugs for the treatment of mental health conditions that the collaborating practitioner generally provides to patients in the normal course of practice, except prescriptive authority for the following shall not be authorized. Patients who are less than 18 years of age or 80 years of age or older, and patients during pregnancy. And subdivision 3, collaborating practitioner shall file the collaborative agreement with the board and notice of any termination of the agreement. So those agreements and practice arrangements are all filed with the board. Issuance of prescribing authority for Schedule 2 through 5 controlled substances shall identify the specific substance by brand name or generic name. Prescription or administration of controlled substance by injection is not allowed under these collaborating agreements. And then we have subsection C, specialty by endorsements. The director of the board may, upon payment of a required fee, grant a prescribing specialty without examination if the applicant holds active psychologist prescribing authority in another US or Canadian jurisdiction, and the requirements for the psychologist prescribing authority in that jurisdiction are in the judgment of the director substantially equivalent to the requirements of this section. And then we have our effective dates. So this section and section 2, which is the duties of the board, take effect July 1, 2025. The reason for that, of course, is that rulemaking takes some time. So if it takes effect July 1, 2025, there's sort of a year runway for the rules to be adopted. And then the remaining sections take effect July 1, 2026.
Go back to the last little C. So is this saying, okay, we've required that they have an examination in order to apply from the relevant specialty, endorsed by the relevant specialty. Is this basically saying that they don't have to redo the examination if they've been, if they already have prescribing authority in another state and has the same or equivalent requirements, which means that they took the exam prior to for another state? Okay. I'm just trying to wrap my brain around why we're doing it without examination.
This is actually a question for you. I looked up the Board of Psychological Examiners, and on the state website, there's actually only one that's current. I'm sure just out of date, but everyone's on this list. There's 5 of them. Their term expired in the past. So there's only one active person, James Hewitt. Will we have a chance to have testimony from the Board of Psychological Examiners, even if it's in writing? I'm just thinking about the rulemaking again, and
It's a great question.
we can talk about it.
Yeah.
Maybe if they're listening, they can update us on the members that are actually there now. I'm sure James Hewitt is not the only person on the board.
All right. Let's talk about it during break.
Okay.
Thanks, Katie.
Yeah.
Any questions for Katie? Please, no more questions for me. All right. Well, thank you. And thanks for squeezing us in.
Yeah, no
No,
problem.
you were
Thank you.
all over the place today.
No problem.
And thank you for your patience. So we have Philip Hughes with us. And thank you for joining us.
Thank you. Good morning, Chair Black and members of the committee. My name is Dr. Philip Hughes, and I'm a health services researcher and research assistant professor at UNC Chapel Hill. My research focuses on how policy impacts mental health care, and I'm here today to testify in support of HB 237. First, I'd like to talk a little bit about safety. I recently published a peer-reviewed study comparing the outcomes of 21,228 patients who saw either a prescribing psychologist or a psychiatrist in New Mexico and Louisiana. This study used the same robust methods that are used by the FDA currently to generate real-world evidence regarding drug safety. So very tightly controlled observational research study. What I found was that compared to patients treated by psychiatrists, prescribing psychologist patients had a 24% lower rate of adverse drug events and a 20% lower rate of using multiple psychotropic medications. they also ended up with similar rates of emergency department visits and medication adherence. So similar to psychiatrists in some regards and potentially safer. So in addition to that, there's also ample evidence to suggest that prescriptive authority for psychologists can improve population mental health. Two studies have now found that suicide rates are lowered by as much as 5 to 7% whenever psychologists prescribe. And building off of that information, a cost effectiveness study has demonstrated that prescribing psychologist is highly cost effective, reducing suicides while also saving millions of dollars in lost economic revenue for the state over a 20-year span. Finally, I want to mention that my research also suggests this bill is likely to increase access to mental health care services. I led a policy simulation study that estimated how prescribing psychology might impact mental health prescriber shortages in each state. And what I found was that HB 237 is likely to reduce the mental health prescriber shortage in Vermont by about 8%. There was a question earlier about how long kind of the ramp up time for this policy is, and I wanted to touch briefly on that. So the ramp up time for getting prescribing psychologists licensed varies a little bit by state, as you might imagine. But the best example we have currently is Colorado just recently passed a law similar to this in 2023, and they had a similar kind of 1 year ramp up period for rulemaking, and they now have 9 prescribing psychologists as of a couple of days ago. So they're ramping up fairly quickly. Also, there's about 1,400 psychologists in the U.S. with the requisite master's degree. So they would likely be able to get into the pipeline to start getting their practicum hours and get licensed fairly quickly. But in addition to the work that I've done looking at prescriber shortages, I also wanted to mention briefly that there's a couple of studies now showing that prescribing psychologists appear to be treating primarily underserved patients, including patients in rural counties, under-resourced communities, and those insured by Medicaid. So in summary, the research to date has clearly demonstrated that prescriptive authority for psychology is safe, reduces suicide rates, reduces healthcare costs, and improves access to mental health care. And with that, I would be happy to take any questions.
Great. Does anyone, could you provide us with some links to your research?
And his
Or-
remarks.
And your remarks, if you have them written, we'd love to have them written, so we can refer back to them. Because you gave us some great data and numbers in there.
Absolutely. I have a research brief that I'd be happy to send around to you all with
Be
links
wonderful.
and citations.
Does anyone have any questions? Oh, Daisy?
I'm not sure who the question's for, but can anybody speak to, maybe Philip, your research can speak to this. I'm curious if a patient is to get access to medication to treat a condition, and then they move somewhere, and they move somewhere that they don't have similar access. Maybe they stay on the medication, they're able to continue the prescription, but they don't have the therapy component of care. How do they get medication management in a new location? Like, I'm just thinking about the continuity of care in a different situation. Like, I'm in a situation where I've been on an antidepressant for 10 years, and only now am I really getting the medication management from the right clinician who can address that. It's basically been, patchwork medication management for the last 10 years. And my fear is that other individuals would get in that situation, right? Where there's not a clinician who knows how to manage the whole cocktail that other clinicians have been piecing together as that person moves around. So can you speak to the quality component of the longitudinal medication management?
That is a really good question. So in terms of prescribing psychologists, there's really not much information yet available on kind of what the continuity of care looks like as far as, handoffs to other providers. In general, though, my understanding of the mental health workforce is really well reflected in your description of kind of a patchwork of You know, if you don't have a specialist provider available who does all of those things, you kind of have to go look for, you know, a prescriber who can manage the medications and a therapist who can manage therapy and possibly somebody else in the mix who can, you know, help coordinate that care. And I think that is one of the things that anecdotally I have heard has been really successful with prescribing psychologists is that it does kind of consolidate that need for multiple providers into one provider who has got the specialization to do both medication management and therapy. And in a lot of cases, really, one of the things that the prescribing psychologists have been successful at is deprescribing. So taking that kind of mix of, you know, the laundry list of medications that a person comes in with and being able to say, you know, really you don't need these three because they all do the same thing as this one other drug that you're taking. And being able to kind of deprescribe is one of the first things that they're really touted for, and as far as being able to manage new patients.
Topper?
With the 2-year clinical work that has to be done with a prescribing physician, wouldn't that psychologist, doctoral psychologist, learn during those 2 years that you have to look out for that? Multiple prescriptions, maybe
Yeah.
from another place, wouldn't that trigger in the person's mind? Your primary care physician does that all the time. Takes a look at the prescriptions you take.
Yeah, absolutely. I
And if
mean,
they're working in conjunction with one for a couple of years, I would think that practice would follow once they get out on their own.
yeah, they would absolutely pick up that skill set of, you know, kind of consolidating medications. And I think one of the things that's really unique with this is that with that kind of patchwork that patients have to go through, oftentimes you encounter patients who have one medication from one physician, and then they went to, you know, the kind of doc in a box down the road that, you know, does one-off appointments, and they got another medication from that provider, and then they went and saw a nurse practitioner at this other place and got a prescription from that provider. And because we don't have a highly integrated healthcare system in the US, those providers may not have any idea about the different medications that they have all prescribed for this patient now. But whenever they come into a prescribing psychologist, that psychologist is going to get their list of medications from the patient and be able to talk through kind of why are you taking this drug and this one, and, you know, work with the patient to kind of narrow that down to what they actually need.
Thank you.
Great.
Mhm.
Thank you. Any other questions for Mr. Hughes? Thank you very much.
Thank you.
And we're joined by Sarah Hastings at St. Mike's.
Hi, good morning.
Morning.
I'm going to speak to you today as a licensed psychologist doctorate who has seen mental health treatment change lives for the better and promote positive adjustment, not only for the patient, but by all of those who were touched by the patient's life. I can also speak to you as someone whose close circle of family and friends have been impacted by the devastating effects of untreated mental illness and suicide. So over the course of my career, I've worked with patients in clinics and university counseling centers and private practice. And currently I'm a professor of psychology at St. Michael's and direct the master's program. When my work here is largely training frontline master's level clinicians to apply evidence-based psychotherapy in their work with clients. Psychotherapy does make a tremendous difference for a lot of patients, but for some, medication is needed to promote full functioning. And in my opinion, this bill addresses the widespread shortage of skilled doctoral level providers who can help patients access comprehensive care. As others have said, and as you know, across our nation, long wait times and low availability of psychiatric services are well documented. And people living in rural areas are especially impacted. This is not a new problem. When I completed my PhD 26 years ago, I worked as a new psychologist in a rural outpatient clinic in the Midwest. And at that time, if my patients needed to see a psychiatrist, their choices were to drive 2.5 hours to the nearest metropolitan area, or to wait for the rotating psychiatrist who came to our rural clinic twice a month. And since that time, the access to care has only grown worse. And here in Vermont, the average wait time to see a psychiatrist is 54 days, and that's according to a 2022 report from the Vermont Agency of Health Services. And a recent national survey found that 80% of psychiatrists were not available to take new patients. And the median wait time for in-person appointments among those psychiatrists who could see new patients was 67 days, so more than 9 weeks. So the bill before you offers a solution to the significant shortage of psychiatric services in Vermont, and it balances patient access to essential life-saving mental health care with patient safety. It also, ensures that prescribing doctoral level psychologists obtain advanced training with a minimum of 2 years of specialized coursework in psychopharmacology, supervised practice, and the completion of the national certifying exam. And as already mentioned, 7 states have granted prescriptive authority to psychologists as well as several federal agencies. And Dr. Hughes mentioned his article in the journal Professional Psychology Research and Practice, which I was going to mention as well. And Vermont was cited as one of the states in particular that would see the largest reduction in prescriber shortages as a result of the statistical model that he implemented. Doctoral level psychologists have extensive training applying psychological science to help promote well-being in their patients. They have coursework and supervised experience in diagnosis, assessment, and psychotherapy. And their training in these areas far outweighs that obtained by physicians. Over the course of my career, I've seen how effective talk therapy can be. We are social beings who benefit from emotional support, insight, a professional relationship with someone who can help us explore new options and face emotional pain and encourage us to apply compassion to ourselves and others. And for some patients, the combination of talk therapy and medication makes a life-saving difference. Helping patients live the most effective and rewarding lives possible is our goal. And for every patient successfully treated, there's also a network of family members, friends, neighbors, and coworkers who benefit. So I'm urging you to support the movement of this bill forward to help update the mental health care system in Vermont and ensure that all Vermonters can access the care that they need. Thank you.
Any questions for Sarah? Go ahead.
Do we have a copy of what you just told us?
Do you want to send us written testimony? I mean,
Be happy.
basically the testimony you just gave, that would be great. We love referring back to it.
Absolutely. And I can send you the links to the studies I referenced as well.
I have a question, a very basic question. I'm looking through the bill and I'm thinking about, MDs and psychiatric nurse practitioners. So explain to me the years of education training that go into becoming a doctoral level psychologist, and then how the training that would go into then receiving a postdoctoral training in psychopharmacology, which would be a master's level, correct?
Yes.
So can you add up for me like the years?
It's a lot. That's a lot of years. Yeah, so doctoral programs typically are about 5 years, and I took a little longer route because I got a master's degree, but then went into a doctoral program. So typically, again, a doctoral program will be 4 years of concentrated coursework, which include as a part of that supervised practicum experiences where you're providing therapy under supervision. And then your final year of the program, you're at a full-time internship, generally accredited by APA. And that internship, you are working with a staff of psychologists under supervision. So you go through that. You have a dissertation, obviously, as a part of your doctoral program as well. And then once you've got your degree, you pass the exam. It's called the EPPP. And so you pass that, and you have another year of postdoctoral supervision before you're eligible for licensure. So yeah, so that's the path of a doctoral level psychologist. And then yes, this the master's is a 2-year program, and there are some online options for getting that. And I have not done it. I've listened to others talk about the various courses and procedures that are required, but I'm not having done it. I can't speak with a lot of authority about that.
Okay, thank you. It sounds exhausting, frankly. Yeah, go ahead, Topper.
Brandon, do you have that? What you started out that she didn't get?
No, I would have to get that as well. My colleague, Dr. Rick Barnett, has that.
I can show you a comparison of all the different disciplines with what's required to get an MD degree, a nurse practitioner degree, a physician assistant's degree, prescribing psychologist degree.
So in your testimony, you bring
I
that
can
up.
mention that, yeah.
All right, thank you. Thank you, Sarah.
Thank you.
Next up, Lauren and Jen.
Do you want both of us up at the front?
Not unless you both want to be up there at the same time. Whatever you both
Jen,
feel.
why don't you come up that way? Yeah, that way you had more to add, it will just be easier. For the record, my name is Lauren Hibbert. I'm Deputy Secretary of State, and I have with me
Jennifer Colin, General Counsel for OPR.
Hello. Thank you so much for having us. We have essentially the same testimony, so it wouldn't make sense for you to hear from one of me and then hear from her. So, and I'm going to primarily lead on this one. We have conducted a study of prescribing at the doctoral level for psychologists. We published a report in this January, and it is available on your legislative reports page. I can also send it directly to the committee if that would be helpful, or it might be in the additional resources for your committee. Our recommendation did not exactly align with the Vermont Psychological Association, the VPA's proposal. We had some alternative recommendations in our report. And as such, we do have, if this bill were to move forward, we do have some modifications that we would be seeking. But on whole, we support the concepts within this bill, the passage of this bill. We just have some things that we would want to be clarified. Essentially, we recommended the creation of a prescribing specialty. I just want to note that in the bill, it says a prescribing license. We would need that to be changed because we wouldn't want it to be another license. We would want it to be a specialty that stacks on top of the license.
Our legislative counsel, Katie, first off said that she put the wrong word.
Okay, great.
And she's flagging for us everywhere where it says license. Okay.
The second big, well, let me back up. The reason why the Office of Professional Regulation feels comfortable with expanding the scope is that we do think that there is protection through increased education, an additional exam, and experience. And we really looked at examples across the nation where this is happening. And we think that it has shown to be successful in other places without harm to the public, because our baseline requirement at the Office of Professional Regulation is to make sure that the public is protected at all times. So we look at it through that lens. Of course, we look at it through expanding access to care as well, but our first concern is protecting the public. So our first recommendation is around how it's in the bill. It requires a postdoctoral program accredited by the American Psychological Association or its successor. Technically, the APA doesn't accredit them, but we do agree with the concept. We just think accredited should be substituted for designated because it's not an official accreditation. Accreditation means something different than what the APA is doing. We support the way that the bill currently is drafted around the examination. It gives OPR the authority to determine an appropriate exam by rule. We think that is appropriate, and we will, if this bill moves forward, we would do rulemaking and designate an exam for these folks who are seeking this prescribing specialty to take. And we think that there is an exam out there that is appropriate. So the biggest piece of difference between the bill and our report is around experience. We recommended a post-degree 14-month clinical rotation. And in that rotation, there would be significant experience in a variety of modalities. And this is a similar hands-on experience that nurse practitioners have. We think that that is appropriate, given the medical, personally, I don't like when mental health is not included in medical, but the like physical medical as opposed to the mental medical knowledge that is necessary for prescribing.
So we require psychiatric nurse practitioners 14 months clinical rotations?
All APRNs.
All APRNs, okay.
But psychiatric nurse practitioners do as well.
And I'm sorry, what is in the bill currently?
I don't have the bill language in front of me, but right now it's 2 years of supervised practice, not less than 20 hours per week in a clinical setting agreed upon by both the psychologist and the collaborating practitioner. That's on page 5 of the bill.
You're requesting we actually align it and make it less.
Well, 14 months, it's more prescriptive. It's 9 practice settings. So it says which practice settings they're in. And we think that's important. And also, we came to this recommendation because we looked at the Illinois model, which is a very successful model, and is more prescriptive than just what the clinical settings that are agreed upon by the person seeking the specialty and the collaborating provider.
And
Go ahead, Topper.
9, just so that I clearly understand, 9 different settings
Yes.
in 14 months.
Yes. So specifically in psychiatry, pediatrics, geriatrics, family medicine, internal medicine, emergency medicine, obstetrics and gynecology, surgery, and 1 elective.
Just so that I clearly understand that. That would be a little over a month in each place, as opposed to 2 years in one place.
But it could be 2 years in only one topic area, and it would be in a private agreement between the person seeking the specialty and the collaborative provider. So someone could do 2 years, but it could just be in family medicine, or it could just be in geriatrics. And we think that the diversity of experience, particularly because a lot of folks who have the specialty will not just provide care to one type of patient population. We think that the diversity of experience is important. And it's more similar to the models in medicine and nurse practitioner care as well.
So was there was it the Illinois? No, which one did you,
We looked at the Illinois model as sort of the gold
and
standard.
that's what they do?
That is what they do.
And it's successful? The
Yes.
people are getting enough training?
Yes, and it's set out in the statute as opposed to an agreement between the collaborative provider and the person seeking the specialty. Whereas here it is 2 years of supervised practice for not less than 20 hours per week in a clinical setting that's agreed upon by the psychologist and the collaborative practitioner. So the state doesn't have oversight about that agreement in the way that this bill is currently drafted.
Can I just ask a practical question?
Yes.
So this is once, okay, so they are able to prescribe, they're prescribing during their clinical rotations in those first 2 years, or in the 14-month range. But we're going to put them into a pediatric practice, but they're not able to actually prescribe to anyone under the age of 18. And we're going to put them into OBGYN. Well, I realize that GYN encompasses more than just being pregnant. But so what would they be doing in a pediatric practice?
So
Prescribe anyways.
they would be learning how other prescribers assess whether or not pediatric patients. I mean, it's really, this is a time to learn the physical medical things that need to be considered before prescribing, and not just the mental health medical things that need to be considered. And pediatric, yes, most of us think of pediatric as up to 18, but it actually goes further than that. And this training in this bill, and certainly within our report, would be required before the psychologist would be able to prescribe.
Great, thank you. Oh, I'm sorry, Casey.
In Illinois, do prescribers at this level prescribe do they do pediatrics?
Don't believe so, but we can get back to you on that.
I can Google it.
Okay, sorry, I don't
Gentleman
know.
is nodding, I mean, shaking his head on that.
They do not. Okay.
Thanks.
So we would be looking for that modification because right now in the bill, it does allow OPR to do rulemaking about the length of rotations and appropriate institutional settings. But it's not clear whether this would be the same as the clinical rotations as we recommended in our report and is in the Illinois model. And we would just prefer that those requirements be set out in statute as opposed to in rule, because we have found over time that's more clear and provides clear expectations for everybody.
Mari?
Just because I'm gonna have to step out for a quick meeting at 10:30. I had a question earlier when I went to look at the Board of Psychological Examiners. It looks like it's not up to date. There's only one member of the board who's actually has an active term. Everybody else is expired in 22, 23, 24.
Yeah.
So what that means is that those folks are still serving while we're waiting for more appointments from the governor's office.
Okay,
We have a functional board. We just are dependent on the governor's team to appoint people, and that takes time. And so people serve until the new member is appointed.
okay, thank you.
That's a long time.
I was what year?
2022.
Okay, thank you.
We have that issue. I mean, we actually, at this moment, I want to be very clear, we have a very strong relationship with the governor's appointment team, and they are doing active appointments, but there is a backlog, and it is hard to find people to serve on our boards as well. So particularly in mental health professions, where these professions are already stretched pretty thin in terms of availability. And this really is, you have to dedicate usually about a day, a month, at a minimum to serve on a board, plus disciplinary work. So it's probably 2.5 days a month of work that someone is dedicating with $50 per diem. So it's not easy to find people.
It's helpful, thank you.
Yes, thank you. Chopper.
This 9 different rotations. Does this mean that OPR would allow those people who go through that to prescribe to people under 18?
No, not in the way that our proposal in our report found. No.
I don't want to be confrontational at all.
I don't find you to be
I'm just trying to figure out in my mind, why would we do that? If they can't, they're not gonna be working with any of those people.
Well, I think.
I'm sure you must have a good reason.
Yeah, the rationale is that people who prescribe medication need to understand the human body and the human nervous system and all the whole body from birth to death. And that is not something that can be learned in isolation or pieces. And the difference between someone who's 18 and someone who's 17 is really negligible. And they both are in the same group of people. And arguably someone who's 21 is not that different than someone who's 18. So in terms of brain development, depending on, a lot of factors. So, for individuals who are affected by trauma, that can be even more so.
And my last question.
So you can ask me as many as you want.
Don't you feel that in that 2-year time working in that office, that physician would be treating people in the age group, the areas that you're thinking of?
Candidly, no.
Okay.
I think physicians do specialize in certain groups of people and may not have all of those groups.
Thank you.
Yes. So we do recommend those amendments if the committee is amenable. We also would recommend to the committee that that you look at the definition of drug. Currently, the definition is an agent related to the diagnosis, treatment, or management of a mental, nervous, emotional, behavioral, cognitive, or substance misuse disorder. We do find this language maybe a little bit outdated and could exclude ADHD and other disorders that are more brain related and not as much, may not fit into the definition that's currently in the language. So we would recommend tying the scope more closely to conditions that are within the DSM and or creating rulemaking authority for OPR. That would provide more flexibility to these prescribers and allow for them to treat a wider diversity of patients ultimately than the current definition allows from our estimation. We also recommend that that the drugs be expressly stated in the collaborative practice agreement, or that we create a statutory definition tied to objectively knowledgeable standards. Currently, the way the bill is drafted is it says that the psychologist would prescribe only those prescription drugs that for the treatment of mental health conditions that the collaborative practitioner generally provides to patients in the normal course of practice. That's really a very opaque definition of what's allowed, and it's very unenforceable for our office. We would have a very hard time being able to say that someone with this specialty went beyond what is expected, because we do not know, nor do we have a way to prove what is in the normal course of practice for the collaborative practitioner. We don't have access to the collaborative practitioner's medical records for other patients due to HIPAA, which is a good thing. But it would just be a very difficult thing for us to prove. And we would ask that OPR is given rulemaking authority to forbid certain drug classes. Specifically, we would be considering forbidding the prescribing of opioids and other narcotics because of opioid misuse. And we believe that that class of drugs really needs to be prescribed by a certain subset of clinical prescribers.
So would you recommend eliminating a schedule or just classes of drugs? Like right now, I think it's schedule 2 to 5.
Right. I would need to speak with our executive officer of pharmacy to just make sure, because I get candidly, I get confused between those two things. So I would want to just confirm that I'm giving you the right information.
Or you're asking for the ability in rulemaking
Yes,
to
that is our ask, that we have rulemaking authority to
limit
determine that.
a class of drugs. Specifically, you're thinking about opiates.
Yes.
Okay, thanks. All right, did you have a question?
I was just thinking along the same lines, and I couldn't remember what class like ketamine
I
is.
think they're in two.
I don't remember, so
See, I don't know. That's why I don't want to answer, because I don't know whether we would want to prohibit ketamine or not. And I don't know if that's a policy decision. Well, actually, I do know that's a policy decision I should not make right now to you today in this seat, because
Yes.
I don't know.
Frankly, also around here.
Glad you have a resource you can
Yes.
ask.
All right. Thank you. I think that's it, right?
Those were the big things. I mean, we have the drafting issue of license versus specialty. And we also would ask for a longer implementation time. Currently, the effective date of this bill would be in January of 26. But as we just talked about, we need to do rulemaking in this profession for this specialty. And as this committee heard me testify about earlier in the session, we did this major mental health licensure study that recommends restructuring of all of the mental health professions except for psychologists. But that means we have a major rulemaking project ahead of us in those professions. And it probably will require some rulemaking changes in psychologists, because we did find some ways that we could do a better job licensing them as well. And we would like for all of those rulemaking projects to line up. And if we put the effective date of 7/26, they will not line up because we are moving the mental health restructuring bill next session in 2026. And so we will, assuming we have success, we'll be in front of this committee next year quite a bit. Assuming we have success in front of this body, then we will be engaging in major mental health rulemaking reform in the fall of 26, spring of 27. And so we really need this to be effective either January of 28 or July of 28. So we have the runway to get this set up the right way.
Also, if this is something we decide to move forward, it actually would be helpful for you to know that that's coming, because you can include it in all the other work you're doing around mental health professions. Do you have a question, Tucker?
I think what you just did is answer my question.
Oh.
I just felt that would, we got a problem right now and we're trying to solve it.
Yeah.
Wait to 28.
Yeah,
And I know you understand.
I completely understand where this committee is. And, I do want to say, and this is on the very last page of our testimony, we did not find that there's going to be a rapid increase of prescribers in the state as a result of doing this. That hasn't played out as much as expected in other states. We think that this is a good policy. We think that it's a safe policy. We think that it's a rational policy. We could not objectively find that this would increase prescribers by 10% in this state. And so we think that it is a good step. It's a good piece to bring to our mental health care system in Vermont. But just want to caution that we don't know that it's going to solve a big prescriber gap. And if this moves forward, as we've done in the past, we probably will ask for a general fund allocation to help us set up this program, just because this is a new program and shouldn't be borne by everybody. So I wanted to make sure this committee understood that. And we haven't determined what that would be at this point.
I'm so sorry. I had a question in my head and it just went away. Oh, I know. It's a simple question. Leslie had asked us, how many doctoral level psychologists do we currently have practicing in this?
That is a very simple
Licenses.
question that I can find an answer to.
Okay, yeah.
It's in the report.
Oh, okay.
Five doctor levels.
How many? Sorry.
580
584?
doctor levels. License.
And how many might want to choose to move on? You have a sense?
To take the training, you need to get the specialty, it's maybe 10-20%. They were surveyed in the report that the Office of Professional Regulation did, and there were many people supported this, and 50% of those who responded, even though only 7% responded, said they would take the training.
So 7% out of
Can
the
we-
500.
Would you mind identifying yourself?
Sure, Dr. Rick Barnett, licensed psychologist, chair of the Legislative Committee for Vermont Psychological Association.
And we'll have you testify soon. Did you have a question, Daisy?
I'm gonna remember it now.
This seems to be the theme of the day.
Oh, the supervisors of these folks would, if they were to pursue this specialty, do they have a regular or periodic licensure review, or what's the recurrence interval of that if they're
Of the supervisor?
Yes.
That is something that is not set out in your statutory language, nor did we specify in the report. That is something that we could do rulemaking around. Certainly in our mental health licensure study, we did find that we needed some more supports and structures around who are the supervisors. But we did not address that in this report. But that is something that we could do rulemaking around. And it's not currently within your bill before you either. The requirements on the supervisor besides their licensure levels.
So, when we were talking about the number of these individuals in the survey that was done, so that I clearly understand that, we talking about maybe 50 of these people are willing to go through this extended,
We think, we found after doing our survey, again, like Dr. Burnett said, we had limited participation. Small number of respondents, and of those 50% said yes, but it was less than 10% of the population who responded. So we really don't know. And we found that it could be, a decade until we get 10 or more prescribers. Now, that doesn't mean that it's not good policy. It's just that this is something that's new in this area of practice. It is going to require additional school, additional training, and additional exam. We know that those are barriers to people just saying, yes, I'll do this. It takes time. So it will probably be, the training itself will probably take a period of years, and then people have to agree to do that and take that on. And so that it will take time for us to get.
So, I mean, even if we changed it to 1/1/28, presumably if somebody was really wanting to do this, they would be ramping up and getting training and getting the master's level.
Yes.
Right. So that takes years. Apparently we found that out. It's years also.
Yeah.
It's exhausting.
and I understand all of that. But as I went through those figures as they were being told to us, it seemed to me that there were 500, was it 500 that responded the last time?
No, there's 580 something total licensed in the state,
Okay,
and 10% of that group responded to our
that's
survey.
50.
Yes.
And
And
of those 50,
25 said they would be interested in this pathway,
okay, so 25 we're talking about.
approximately.
Yeah. Okay, 25.
But the important thing also is that by implementing this program, we could have people move to our state who have this authority. And that is an important thing as well to consider.
And I really appreciate those figures, because that, in my mind, says that probably 2 people in each county in the state of Vermont, if we're just looking at the map, there'd be 2 more people in those counties that could prescribe.
And while that is a small number, it is not an insignificant
No,
number.
I think it's a big number.
But it's just, we want the committee and the public to know that we don't anticipate that all doctoral level psychologists will pursue this. We don't know how long it will take until 50% of them pursue this. It's a long on-ramp because this is, I mean, the program, as Dr. Barnett said, to become a doctoral level psychologist is an extensive program. It's very difficult to get into those programs at the outset. And then those programs are difficult in and of themselves. And so this then adds another layer of extensive education, which our office believes is appropriate, given what the scope expansion. But it is another hurdle or burden, depending on which word you want to use, for that person seeking that specialty on top of their license. And one that they very much want. So I think many may pursue it. We just don't know how many.
Yeah, that's the unknown. I tell you, 2 people in Washington County, to me, would be a big number,
Make a difference.
make a huge difference. So thank you very much for all that
Yep.
information.
Any other questions for Secretary of State's office?
Thank you for your clarity.
Thank
So
you.
accessible.
Yes, thank you. And thank you for your written testimony with all your and suggestions.
And we'd be happy to work with legislative counsel on exact language if that would be helpful to your case.
Like tomorrow.
We could probably help you. Today, this afternoon would be even better, if possible.
But we have a possible vote, so that's the only reason I'm bringing it.
Tomorrow,
Yeah, tomorrow.
So if we could start working, it would be ideal for us to not work on it tomorrow morning, but instead this afternoon and tonight.
Yeah.
Whatever way.
It would be, we're having some, our legislative council is otherwise occupied.
So-
A lot, but I do know I know she has this,
Okay.
these suggestions and these edits.
And it would be important for me for this to get integrated,
Yes,
to be able to move forward.
yes.
Can I ask just a very brass tack question? Do you want us to work on those amendments and send them to legislative
That
council?
would be wonderful.
Okay, and then you folks can decide which of them you like or don't like.
Yeah.
But we know what amendments we'd be seeking and can,
That would be great.
okay.
And I'm sure our legislative council would appreciate that as
If you're taking a vote tomorrow, that would be best for our office.
that would be wonderful.
Okay.
Thank you so much.
Thank you.
Okay, I think we're gonna take a break. Had a long morning and we will come back. Yes, late after we have a scheduled break at 10:45. But I think we're gonna take one earlier.
So come back when?
Can we be back here at 10:45?
Sounds good.
And then we'll get started from there.
Thank you.
Okay?
Yeah.
Thank you.